call. It's 2 o'clock according to my computer, so we'll get started. Just to let you know, you're all on mute other than those who have speaking parts today. And so use your chat feature in the WebEx to communicate and chat to all participants. And once again, make sure that you have that open. It should turn blue when you have your chat open, that middle dot there that looks a little bit like a bubble on a cartoon. And then you should be able to see the chat box as well once you've got that signed in. So first we'd like to chat who's on the line. So if you can please type your name, the organization you represent in the chat box to all participants. And then if you have a room full of people, type in how many people you are in that location and give your location. So just as an example, 13 for Edmonton Southside. Like we've got lots of people coming up here, so that's good. I see Carrie there. Hi, Carrie. I know you can't say hi back to me, but they have you on. Okay. I'll just keep adding your names as we go along. So we'll go on to the next, just why we come together. So this network was developed to share information about provincial initiatives, strategies, and tools related to improvement facilitation and quality improvement in primary care. So everything that is shared should be operationalized through the lens of your PCN. So ensure that the strategies and tools that you want to use align with your PCN's tactical plan. So whether that's making sure that you've talked with your direct supervisor about that or your ED, whatever that needs to be. Okay, so coming soon to the EMR network. So Lori, are you taking over here? I just need to confirm.
Yeah,
okay,
sure.
So,
I'll for sure talk about this.
Okay, so Lori, I'll introduce you just a little bit in case people don't know who Lori Choma is. Lori Choma works for the AMA, and so she's going to be our main speaker today, talking about several different things around the EMR and how to be able to use it. So there you go. Take it away, Lori.
Thanks, Carol. Just starting out with a few updates before we get into the main portion of our program today. So it's been a couple months, a couple of webinars since we brought you any updates on the provincial EMR network. So most of you will know, if you've been on previous meetings, that we're working on launching a provincial EMR network for improvement facilitators, clinic managers, panel managers, anybody who really wants to join to problem solve and share solutions and engage around their use of the EMR for patients' medical home. So we have a co-design group, just the same way we have a co-design group for the Improvement Facilitator Network, and they're focused on two activities right now. One of them is on building a collaborate site, so similar, same technology that we have, but it's been fairly complex trying to pull it together, looking that we have one main network and then we want to have functionality for each of the 5 major EMRs. So the group is working very hard on the technical side around that, and then also around just organizing leadership for the EMR network. Again, just being able to divide out and have 5 different working groups. So we're still aiming to be able to have a launch in the next few weeks. If we can get everything together, we do want to make sure that we have the technology up and running so it enables us to communicate. So stay tuned. We're still looking to launch, and we'll give you more updates as we're aware. Second update we wanted to bring you was just a reminder. We posted this on the Collaborate site, but to let you know here that we do have licenses for the IHI, the Institute for Healthcare Improvement Open School. It's quality improvement focused, and you can see there's a range of different topics. It is not primary care specific, so it's not specific to our context, but the content in Open School is super high quality. And if you're an improvement facilitator, you'll see the different audiences there that we're targeting with it. It is free to get a license, and you just have to register in a link, and then you'll be sent the information to activate that. It is free, so the AMA is paying for the licenses. It's self-directed, so you can do it at your own pace. It's time limited. I think our license is going to go into early 2020, so it is something that you want to take advantage of in the near future if you haven't already. And at the end of it, if you complete all of the modules that they have, you do get a certificate that you've completed IHI Open School. So if you have any questions, you can chat them in. You can please feel free to post them on the Collaborate site, or there's the link that you see there. You can always ask some questions through the registration if you're unsure. A really great opportunity if you haven't taken advantage of it already. So I'm going to pass the floor over now to Sheena George, who's one of our colleagues working on the CII CPAR project. She's going to provide a couple of updates there, and then we'll move into our main program.
Thanks, Lori. So our latest update on CII CPAR. So we have completed testing for MicroQuest, HealthQuest, as well as the TELUS MedAccess EMRs. Currently, we're working with TELUS Wolf. They've just completed for their consult uploads. So that's one of the data elements that's in CII. They're still in progress for the panel uploads. So that's the CPAR element. For TELUS PS Suites, we're also still in progress with them. So what we're doing right now is we are actively working with PCNs and asking them to engage their member clinics on the awareness and readiness. So some of you may have already been approached by the CII CPAR development and delivery teams. We are looking for interested early adopter clinics that have met the readiness criteria. So that means they've been on one of those conformed vendors, they're panel ready, their clinic PIA is up to date. We're looking at those individuals and inviting them to participate in an early launch of CII CPAR this spring. Next slide.
Oh, sorry, Sheena, I've got the next slide. Can you see it there?
Oh, it looks like there's a bit of a delay on my end.
Do others see the slide that says CII CPAR update continues?
Yeah,
yes.
Come up with mine.
Okay.
Continued.
Now I see it. Perfect. Thank you. So what we're doing for our training is we're looking for participants to learn how to use their current improvement skills to get some advanced skills and walk through what it means to get a clinic through the onboarding process. So you will see on our top website we have a new message for the registration piece. We're looking at, we've added some new videos, and there's some other tools that are there as well. And we also have a self-reflection exercise. So these are all the new things that are happening for those early adopter innovator clinics. The self-reflection exercise is 3 simple questions. QHR Accuro, for those who are using the Accuro EMR system, we will be doing their testing this summer. For e-notifications, so this is what we've been talking about, that bi-directional data feed. So as soon as you're a patient that's on CII CPAR with their clinic, they've gone to a hospital, you'll be able to see in your EMR, that e-notification in your EMR. That development is expected to launch with the first HealthQuest, MicroQuest EMR, and that'll be late 2019. And the rest of the vendors are coming afterwards for early 2020.
Ashay, did you have one other piece you wanted to solicit, perhaps?
I do. Thank you so much. So we have just, we're in the middle of improvement facilitator training. We're doing our days 3 and 4, May 15th and 16th. And my ask of this group is if you have some improvement boards that you've been using in your clinics either currently or most recently, or you presented something at a conference, if you'd be willing, we would very much love to get a picture of what that looks like so we can start to incorporate it in that improvement facilitator training May 15th and 16th. Your colleagues, your new and upcoming colleagues in the space are looking for some examples. Thank you.
Tina, where might they be able to send that information?
You can send that to myself. So let's see, I can't write on this one. Or could we, I can give you my email address, but is there somewhere that we can put it that they already have access to? Does that make sense?
Yeah, we can put it on our Collaborate site. We'll put it on the discussion board for you.
Perfect. Thank you so much.
Great, Sheena. So moving into today's main topic, it's about advancing our medical homes. And I know if you weren't all on mute, I could hear you all laughing. But those three critical S's in the work that we do around sustain, spread, and scale was what we wanted to talk about today. And so, of course, the focus of what we are sustaining and spreading and scaling is the patient's medical home. And I really like to use this picture as really a touchstone in all of the work that I do. I look at it at least once a day, refer to it many times a day. One of the reasons I just wanted to put in here as a touchstone, but also just to let you know, for those of you who have eagle eyes, you've probably noticed already, the house has undergone an update. And the big update that you'll notice there is that we used to have two foundations that supported our patient's medical home around system level supports and PCN supports, and that there's been an addition of clinic enablers. And so we just wanted to point that out for you to have a quick look at that. A lot of that is not work that we do directly as improvement facilitators. Probably if there was one, it's around those office processes, but really we are focused a lot on those clinical processes. But I would say we're highly impacted by how well our clinics are able to do all of those pieces. So we wanted to just bring this to you today to point that out to you, but of course also focus you on the work that we're sustaining, spreading, and scaling. We want to start out with some definitions just to make sure that we're all on the same page with the work that we're doing. And sustainability is referring to holding the gains of an improvement project even in the face of staff and organizational turnover. And of course, once we've made an improvement, we want to be able to maintain that improvement. So I think this one is probably fairly intuitive for us. So really I wanted to focus down on defining spread and scale. And there was an update done to this, that's not saved, but that's okay, totally fine. The highlight of what we need to get there is there. So spread and scale up, they're sometimes used interchangeably in some of the implementation science literature, where spread refers to the adoption and replication of an intervention in the system. Scaling up is really about horizontal expansion through a system, so just replicating that intervention over and over and getting bigger and bigger. What I wanted to highlight today was I think spread is probably where we just want to make sure that we have clarity when we use the word, is about spreading through the clinic, is that if you're doing work as an improvement facilitator, that you're going to, and you start off small doing an intervention with one physician, but there's maybe 8 or 9 physicians in a clinic, that you're working on spreading those improvements once they've proven successful throughout the clinic. And then you might also think about spreading through your PCN. And then further to that, when we think about going to scale, when we talk here at the AMA, we really talk about scale on a provincial level. So when we talk about panel, when we talk about Alberta Screening and Prevention, when we're talking about CII CPAR, Opioid Initiative, all the great things that we're working, better access, all those things that we're working on, we refer to that large-scale uptake of those things as scale from a provincial perspective. When you're talking at your PCNs, you might talk about that scaling up at your PCN level. So I guess that definition is just about that spread, and it's about your perspective of where you are. And so we think about scaling at the provincial level. There are organizations, and we think about an initiative that's coming right now to us shortly around e-prescribing and Prescribe It. We're thinking about scaling up in the province. It's a national organization who's looking at implementing it. Of course, they're looking at that scaling up nationally. So just wanted to highlight that around spread, is that different people are going, depending on your perspective, you might talk about that a little bit differently. And I think we're actually going to see that in one of our examples today that we're going to hear about from one of our IS. And so we're going to jump in and start talking about sustain and sustaining games. Oh, somebody put us on hold. We were just talking about having an improvement facilitator network theme song. That might have been our theme song that was playing just a moment ago. Anyways, back at it, sustaining gains. Now, of course, there's a lot of literature and information out there on how to sustain much more than we could fit into a 1 hour webinar, less a 1 hour webinar with a couple of other topics. So it's the main piece, and really one of the important, or the key finding when looking at sustainability and talking about it at the clinic level, is getting engagement of the frontline staff. So that is how you are going to enable your sustainability. And so a few strategies, and this work comes from the IHI. Those strategies are standardization, so making sure that things we can replicate the way things are happening. And so it might be standardization of a job description. And so we want to be able to talk about it from that level, and then also our interventions of care. Accountability, that's really about the ways to keep teams accountable to that standardization of the work that the work groups have agreed on. So everybody in the clinic should know what they're supposed to do, and there should be a leader that's keeping all of those individuals accountable. Visual management systems. So this is a great segue from what Sheena just asked us. So is there a board? It's often a board that you see mounted on the walls, but it helps people to understand what the performance is for whatever improvement it is that you're doing, or maybe multiple improvements, and that matter to the staff and to patients, if it's also visual to patients. So again, if any of you have those examples, it's a really important tool that the literature shows us is important for sustaining gains. Daily communications, huddles. We talk about huddles a lot in the innovation for the PACT initiative, and in effective teamwork. It's a really, really great tool for us to use at the clinic level. And that lastly here, strategy for sustaining gains is a problem-solving technique. So that there is a way to escalate issues, to address problems that have to do with your improvement performance, ones that just can't be solved on the spot. So how do you go back, and maybe that takes you back to some of those daily communications, but then how do you actually get at problems that might need a little bit more attention. So we just wanted to pause here and have you send in some comments to the chat box. And maybe this is your opportunity, too, to let Sheena know if you have a visual management system such as an improvement board. But have you used any of these strategies with your team? And do you have examples to share, maybe that aren't in this list, or just something more specific about what's there? So we'll just pause for a minute. Maybe play our improvement facilitator theme song.
If we had a singer in the group, they could kind of run. Hey.
All right, we've got one coming through there. So Red Deer PCN, so some screening rates, posters, verification rate run charts. Okay, so great. So you're using a visual management system, some improvement pieces. Sheena, that might be one of your groups to hit up. They seem to have some pieces that they have visual for others. I know there's several people who are using improvement boards. Huddles, anybody working with teams on huddles? Yeah, daily huddles. Thanks, Emily. Anybody working on EMR processes? That's usually whenever I'm talking about EMR, standardization is the key one that comes to mind. All right, Faith, we'll read that out. We spent time standardizing processes in the clinic. This improved staff engagement and communication, as when a process was not being followed, the staff knew where to start with communicating with their team. We also had a team huddle every week. Fabulous. All right, team meeting. So yeah, again, there's that communication piece. Likely some problem solving going in there. Communication book. Red Deer PCN is on fire today. Thank you so much. All right, physician dashboards. Perfect. Please keep them coming in, especially if you are writing. Keep going. We'll keep track of those and take a read of them. All your colleagues will as well. But wanted to pass the floor over to our first speaker, Laura Dusky, who's with the Sylvan Family Health Center and part of the Wolf Creek Primary Care Network. And she was going to talk to us and just share some of her reflections and experiences in her clinic with sustaining. So, Laura, we'll pass it over to you.
Great, thanks, Lori. As Laura mentioned, I'm Laura Dusky, clinic lead and improvement facilitator here at Sylvan Family Health Center. And so one of the projects that we've kind of been working on for some time is kind of around collecting data with demand, supply, and activity. And so when our clinic initially started collecting this about 4.5 years ago, the QI team met and kind of worked through the processes. Once they've developed that process, they created standardized tick sheets for collecting demand. And so, they created the process, they created standard tick sheets, they spoke to all of the team at a staff meeting, explained the process and how it worked, and shared some of the graphs and what they would look like. We thought we had a really good plan and system in place. So in the beginning, it did take the team a while to catch on, and so to kind of help that process move along, we use daily huddles as reminders to, make sure you're ticking, and they also created some slogans like tick when you click. So every time they clicked to make an appointment, they would tick for the demand on the demand sheet. They also moved the demand sheet so it was right in front of them by their keyboard. So it was easy to see. It was a weekly reminder. They also created just sticky sheets that they posted on their monitors for a visual as a helpful reminder. And then some of the other things, when we found we were really struggling, they would send urgent messages in the EMR so that it would kind of pop up in your face. And, so all of those visuals really helped, and it helped create kind of a standard. So it was about a month or so. Things were kind of moving along really smoothly. We would review the data at every weekly QI meeting. And every time that we had some staff turnover or new members of the team were starting to book appointments more frequently, we realized that our demand became really mismatched. And so, we worked through some different things and tried to figure out what was going on. And we realized that people didn't understand the why. So when new staff started, everybody knew if it wasn't part of their main task, they knew why. They knew that they had to do it, but they didn't understand the why. And so once we explained why we were doing it, what outcomes we were looking for, it really made a difference. And so that uptake happened much more quickly. And so what we did is incorporated that into our onboarding system so that every new staff member would have a time to meet with the improvement facilitator and get an understanding as to why we were collecting that data, what we were looking for, and it was pretty smooth sailing after that. Does anybody have questions?
Thanks, Laura. While people are thinking about their questions and typing them in, I'll just go back. Thanks so much. You did a great job of telling us your story, but I noticed that you hit all of those strategies, the strategies that we picked out from IHI about sustaining gains. You talked about how you went back and standardized. There were things in there about the accountability. You were showing your data, sharing your data. There was a lot of communication happening. You had a problem, maybe not a huge patient safety issue or something like that, but you had ways to solve your problems and circle back. So heard examples of all of those in there. And I'd like to add another bullet to the list that we presented, and that's a slogan. So I love that you guys had a slogan. Often, help you to remember things. So if anybody else has slogans, love for you to type them in. If there's any clinic slogans or IF slogans that you have, please share them. All right, so no questions coming in so far, but thanks for all of you that kept adding there. Oh, Sheena wants to hear your slogan again, Laura.
Sure. Our slogan was tick when you click. And so that meaning that every time they clicked in the EMR to make an appointment, they would tick on their demand tick sheets for collecting the demand data.
Great, thanks. Yeah, and thanks for all the comments coming in the chat. Great, thanks, Laura. So next we will talk about spread. And of course, again, depending on your perspective, we might be talking about spreading within a clinic or spreading some of the work and the improvements beyond the clinic. And again, this content comes from IHI again, is that there's two key activities when we're thinking about spread that we want to do. And the first one is to set a spread aim. And so we put a couple of examples in there. Oh, I see I missed the date on ASAP. But those are some of the examples. Of course, I didn't write them out as full aims. But for Alberta screening and prevention, that we wanted that participation to be at 2,000 physicians. That goal was also for 2015. Panel was to have 80% of Alberta physicians doing panel processes by 2015. And we've set a spread aim for CII CPAR, and that's that 80% of community physicians will be up and running on the CII CPAR system by 2022. And so we want to actually think about, well, what are we trying to do with whatever improvement initiative that we want, and then how to make a plan to implement that. So that second key activity there is for us to make a plan for spread. And so moving along, Jen Bowles, who is from the South Calgary Primary Care Network, she's an improvement facilitator as well. She's going to share an experience. Now, the title there says Spreading PMH Measurements, but Jen came forward. She's actually going to talk to us about sustained spread and scaling. So, Jen, take it away.
Hi, everyone. First of all, I'd like to give a really warm welcome to Courtney Elias-Watson. She is our new facilitator, and we are so happy and grateful to have her. So welcome, Courtney. I'm going to talk about Plexus today. Plexus is our information-based, it's a web-based information tracking tool, and it's how we engage all our clinics to do medical home. Our PCN is very technologically based, and being that all of our clinics are on an EMR, we thought this would be a great idea to have a tech platform for implementation of the medical home, since we were going to be tracking panel, et cetera, and uploading the information. The PCN wanted to use this tool as a way to engage physicians in medical home, and it was kind of a carrot and stick thing, right? So the stick was that any of the clinics that wanted to be part of medical home had to be on Plexus, but the carrot being the value that they got out of being on Plexus. The information management portion of Plexus allows us to track financial aspects of our relationships with the physicians. They can track on-call, as you can see on the screen. They can track their on-call. They can do all of their validation on Plexus. They can track their ASAP measures. Our monthly newsletter is on there. They can follow up for workshops. And this was how we got the Plexus spread among all our clinics. And I'm not sure if I have these in the right order. I'm sorry, my power keeps going out and I keep losing the screen. So anyway, I hope I'm looking at the right one. The next thing that we did was scaling it up. So we started with 7 pilot clinics, and we worked with those pilot clinics. They were agreeable to being our guinea pigs, and we worked out the bugs. We went back and forth with the clinics, uploading, running searches in the EMR and then uploading to Plexus. And it was a really great and paperless way for the physicians to go on and validate. As you can see from the screen, when the physician logs into Plexus after we've done the upload, they can see the patient's name, gender, date of birth, etc., and then they can validate right there on Plexus. And so it was a more technologically advanced way to validate, saved on trees, and it really engaged a lot of our younger physicians. We added requirements, as you can see, to the PCN service agreements. So when we started, to help us scale it up, when we started speaking with other clinics, it was just part of our initial conversation with them. This is what we were going to do. And our goal was to have all our member physicians using Plexus by 2020. Next is sustaining it. So we can track everything that the physicians are doing on it. We can track when they log on, when they're validating. We can track all their ASAP because they can upload all the searches from their EMRs. Their panel managers, their assigned staff can do TNA right in Plexus, and they can see graphs of their information from the day that they start. The clinics that we have doing EQ5D, they can also track that from their uploads on the dashboards. And we have automated reminders. So this is how we're trying to sustain the work is we as facilitators can monitor our clinics and make sure that they are validating, that they're doing their panel uploads monthly, that they're doing their ASAP uploads monthly, doing their TNA once a week, et cetera, et cetera. And it's been so well received. It's very user friendly. The dashboards are providing feedback that seems to be improving the attitude around physicians taking ownership of their practice. And we have mapped out the most common EMR fields to ensure consistency. So we work with the TELUS EMRs and Akiro right now, and we are looking to build it out to accommodate HealthQuest and a few other oddballs that we have in our PCN. That's all I have. Are there any questions?
I have a question for you. It's Carol here. So just in case as people type there, but so this is tied right into the EMR. Is that correct?
No, it doesn't talk to the EMR. So when we run a search in the EMR, we upload it to Plexus, and it's through a secure database. So it's uploaded to Plexus, and then from there, the physicians will validate. And if there's any patients that need to be inactivated, if you go back to the slide that shows what the physicians will see when they validate, back one more. So you can see the 3 buttons. So if they hit inactive or unknown for that particular patient, that list of patients goes to the panel manager, who then in turn will go to the EMR and inactivate those patients. If they hit unknown, it goes to a separate list that also goes to the panel manager, who can then research the patient, call the patient, is Dr. Smith still your family physician? And that way, there's some patients where the physician will say, oh, I think that patient maybe has moved away, passed on. So after a little bit of research, then the panel manager will make those changes in the EMR. And then once we upload again, any patients that have been inactivated will be taken out.
Okay, so the physicians go through this monthly, you said?
Yearly. Yeah,
yearly.
we ask them to.
Yearly.
Yeah, we ask them to do it yearly. But some physicians, like our medical director, she'll go through and do like 40 a month or 30 a month, just so that she's not dealing with a great big list at the end of the year.
So there's a few questions on there. I'm not sure if you can see them, but there's a question there about what % of your PCN has this innovation been spread to?
Well, okay, so we have 61 clinics, and most of the clinics are on Plexus in one form or another. Not all of the clinics are doing medical home yet. We're rolling out. We've still got about 30 clinics to go. But they also log in to do their on-call or their seniors on-call or to read the newsletter. So we already have them engaged for other reasons. And then medical home is also just another part of medical or Plexus for them.
Okay. And then the other comment here is I can imagine some of my physicians saying it's just another thing to do and sign into it for them or staff. And then I recently had that comment about secure messaging. Do you get that response? How do you deal with that response?
Yeah, so in the beginning, it is very overwhelming to log into another program to do your validation. But once the physicians realize that it's just a click of a button, we're getting more and more positive feedback. Yes, it is something else to log into, but you can do it. They can do it on their phone at their child's soccer game or, at the airport while they're waiting for a flight. And there's no printed paper. I mean, there's some, we have some older physicians that still prefer to do it on paper, and that's fine. We'll do it on paper, but we still, when we upload it to Plexus, they still need to go in and hit activate. So sometimes that's assigned to somebody else, but most of the physicians actually appreciate being able to do it anywhere, anytime.
Great. I don't see any other questions coming up.
Jen, I've got a couple of questions
Sure.
for you. I shouldn't say not really a question, but I like the system and about how this is really a tool to help the team to sustain their game and a way for them to see their data and to keep up with their data. So I really like the tool. One of the pieces that I noted here is that you have a goal. So you set a spread aim is to have all member physicians using it by 2020. And I think that's a great goal. I wondered if there was maybe a goal more specifically because you said, they're using it in different ways or to different extents. If maybe you were looking at that or had maybe some more specific goals. But then also just wondered, and I know you said that you are looking at spreading PMH more broadly, and so maybe it's a Plexus plan or a PMH, but if your PCN has a plan for spreading PMH, and I guess I would ask that question to all of the IFs on the call, whether or not you have a specific spread plan for your PMH work or specific pieces of your PMH work.
Well, we are now, probably in the last few months, I guess I'd say, we're really pushing the medical home. We really held back for a long time while we worked out the Plexus bugs. And now that we feel we have a procedure and a process, now we're really rolling it out. So we're contacting all our clinics. They're doing events to talk about medical home. Our medical director is sharing her information with the SAPCA board. So it's really, there's emails going out. So there's kind of a huge push right now to all our medical home or to all our clinics to invite them into medical homes. We have about half on board now, and we're hoping to have the rest by April 2020. So we are hoping to have all our clinics on medical home by April 2020. Great.
So a spread, a plan, and an aim. Love it.
Yes, yes. And yes, the IS can see data in Plexus too. So we are kind of the rulers of Plexus. We have full admin access. So if we log into Plexus, we can see what's happening with all of our clinics all the time. So we can assign users. We can so when we start working with physicians, almost all of them have a login already because they're using Plexus for other reasons. And then when we implement medical home, we assign, whenever the clinic assigns a panel manager, we give that panel manager access and train them how to use Plexus for medical home.
Great, Jen, thanks. And so please, if you guys have any questions later for Jen or any of the speakers, feel free to use the Collaborate site chat in there as well. Oh, one more question came through for you there, Jen. Is there a cost?
No cost. No cost at all. It really, truly is wonderful. Yes, it is one more thing to log into, but I said earlier, the carrot and the stick, right? The carrots that they get, you know, we should have a bunch of happy bunnies because they get a lot of information and a lot of support through Plexus.
Okay, thanks so much, Jen. I think we'll move on to talking about scale. And we wanted to bring you some provincial perspectives on it. So we'll just start out with, take you through a few examples provincially. And so I think we've brought this slide to you or a version of it a few times, and it's Rogers' diffusion of innovations curve. And it really is a focus of our work provincially right now, and in our thinking about actually getting us to scale with all of our initiatives. And so what this tells us, of course, is that there's the innovators in the province or the innovators in the work around patients' medical home who are doing this work before it's mainstream or before anyone else is thinking about it. And then there's the early adopters who are looking over at the innovators going, wow, that's super cool. I think I'm going to do that too. And then we hit the valley of death, where if we're going to actually scale up an innovation that is promising and successful, is that we need to get into and have the early majority adopt the innovation as well. And our challenge, and actually everybody's challenge with any change, because this has been replicated many times through many different industries, is that the early majority think and approach the work of change differently. And our local research and international research supports that in healthcare, if we're going to move that early majority, that they need help to do that. And that help comes through a health transformation workforce, and that workforce is us as improvement facilitators. As you go over that tipping point, the late majority, they still need to be prodded along, but a lot of them actually start to look back at what the rest of their colleagues are doing and just start to pick it up because they don't want to be left behind. And then there's the laggards at the tail end of the curve, that other tail that won't pick something up until they absolutely have to, until maybe there's a regulation that says they need to or that there's no other choice. So I know a couple of family members who definitely had rotary phones until they could no longer have a rotary phone. So that kind of defines who those laggards are. And so when we're talking about going to scale, this curve, innovation curve, is something that we reference and we use it to guide our thinking and guide our strategies. And so the provincial panel progress, this is a slide that you should all be quite familiar with, and work that we have collectively taken to scale in primary care to have all Alberta physicians paneling. You saw there we had a goal to get to 80% by 2015, and we're in 2019, or I should say this data is for 2018, and we're at about 71%. So that indicates that we still have some work to do with spreading and scaling the work of panel. And of course, the work that we do is going to continue to accelerate that forward. This data that you see here is from Alberta Screening and Prevention, and is an example of clinical behavior change. It's a slide that we like to show our funders. And you'll see there that we continue to get uptake. So the y-axis there are the number of physicians who officially enrolled in Alberta Screening and Prevention. And the initiative ended. The funding that we had for it ended. We started to move on to other pieces in the AMA, but the uptake continued on. And so this is an example of us starting to climb that curve where we were able to continue to engage that early majority into change and start to actually get over that tipping point. And so with Alberta Screening and Prevention, we actually are over that tipping point with a number. Although we didn't get those officially enrolled attendees, doctors they officially signed up and shared their data. We do know through PCN annual reporting that there are a lot of physicians who are doing this work, and many of you are facilitating that work with different clinics who are continuing to do that. So we do know that we have more than half of our, well more than half of our physicians engaging in screening and prevention activities. And so you'll see here, it's not retrospective data. It's a look forward. It's part of our planning where we have set some CII CPAR adoption targets, and that curve there that you see on the left-hand side looks similar to what our panel and ASAP screening curve look like. And so we've put that out there in a couple of different graphs. Just a quick note there with that orange part, there's PCN physicians, and then there's all of those. We're also targeting physicians who are not in a PCN. So that would be inclusive of family physicians who have opted to not join a PCN. And of course, CII CPAR is also targeted at community specialists who are also going to be using the system. So we'll see. We'll match our actual data over the next little bit to see how we're doing. But here you'll see a provincial scale plan. So I'm going to pause there with our provincial data and see if there's any questions from the group. Okay, so great. I see that there's a few more questions that have actually come in for Jen. So Jen, if you're able to see the chat, or we can read out some of the couple of extra questions that have come in for you there on the chat.
So somebody had already asked about there being a cost. There is no cost at all. Would those PCNs that don't have an IT department be able to implement this? So at this point, I definitely think you could. I would not have said that maybe a year and a half, 2 years ago, but now that everything is tickety-boo, yes, I believe you could.
Great, Jen. I'll clarify. There is a cost for Plexus that the PCN is covering. It's just that there's no cost at the clinic and physician level.
Yeah. Thank you.
So I think that's all for our content today on the main portion of sustain, spreading, and scaling. We do have just a few pieces left here just to take us to the closing.
So just to make you aware of any upcoming training, so save the dates. So we have some improvement facilitator training that's coming. So Medicine Hat in June and July, sometime in there. Calgary will be September, October. Edmonton, October, November. So just watch the Top Alberta Doctors website for those dates once they're finalized. And then the training for the opioid and continuity process improvements, so CII CPAR for IFs. So there were the Edmonton, Calgary dates, Grand Prairie, Medicine Hat. The McLeod River is coming soon, and Red Deer also will be hosting one coming soon. So watch for those dates as well on the website, along with the opioid process improvements that ran in Calgary and Edmonton. Medicine Hat is going to be hosting one. Edmonton has one that's coming soon, and Red Deer also. The dates aren't finalized, but there will be one coming soon to Red Deer. So again, I just encourage you to get onto the Top Alberta Doctors website to find out those dates that if you're interested in any of those training sessions. So there's lots of the training for the I should read my notes here, I guess. Training will be a one-day for these, and they go from 8:30 to 4:30. 75% of the day will be dedicated to training on process improvements for opioid work, and 25% of the day will be dedicated to training on CII CPAR. Topics with the opioid process are model care planning, identification and prioritization of patients taking opioids, patient-centered care, team and medical neighborhood supports, and zone work. And on CII CPAR, it's on readiness assessments, dealing with conflict reports. So attendees are asked to come to training having completed some pre-work and have a team primed for working through the change package. And then resources on the IF network, just to remind you that this webinar will be able to be found on the IF network for you to go back on the collaborative site and review it if you have questions or if there were some links there that you wanted to be able to connect to. You can also go to the collaborative website to find additional resources and other relevant website links. So for any new IFs, if there's any new IFs on the call, please be sure and get a login and sign on. There's lots of information from previous webinars that will be really helpful for you in a role as an IF. And then the next call on June 3rd, the topic is on quality improvement, so looking at information and around quality improvement for tracking it and then giving that information back to your doctors. And the next slide just tells you how to join the Collaborate if you aren't already a member. So you go to info@pcnpmo.ca and look for the IF Network Collaborative website. They'll need to include your first name, last name, email, contact, which PCN you're part of, your role, and then that you would like to join the IF Network Collaborative site. You'll get an email back that will then give you your login information. So this just shows the some of the information that's there. You'll receive the emails and the invites to these IF Network webinars. And if you have questions, you can send that to the IF admin at albertadoctors.org. And just a whole lot of stuff around the webinars and past webinars that you can then access. And you can also share resources or ask questions of other IFs around the province. So the next webinar again is June 3rd. The webinars run the first Monday of each month except for holidays. And we don't usually run one July and August. We'll be in contact with people. So if you aren't listed on the collaborative site, if we don't have your email, then you'll miss out on those emails that will be going out over the summer. And some of the resources that we'll have connected to that. So be sure and get your name and your sign on there. And we'll talk to everybody again on the 3rd of June at 2 o'clock. Are there any other questions from anybody? We still have a couple of minutes if there's questions from any of the participants out there. And from any of the rest of the team that's on here, did I miss anything? If you need to add something that I might have missed or not highlighted appropriately, please feel free to speak up.
So I think we're good. Thanks so much, Carol. Thanks, everyone.
Okay.